welcome in this new scientific webinar, the first of our 2022 series. Today, I'm very pleased to invite Professor Loïc GARCON from University Hospital of Amiens Picardie, France, who will be pleased to provide us a complete biological and clinical overview of erythrocytes membrane pathologies. As usual, we'll be back after the presentation to answer the question. Please enjoy and welcome, Loïc.
Thank you very much. Can you hear me? Is it
yes, perfect.
Okay, thank you very much for inviting me for this presentation, and good morning or good afternoon, everyone. I'm going to share my my presentation. So do you see something or not?
Yes, it's okay. Just
you see the slide?
Yes. Thanks.
So is it in a diaporama
yes,
mode?
now. Absolutely. It's nice. Okay. Thank you.
So my name is Loïc GARCON, and I'm a hematologist in Amiens University Hospital. It's a city north of France, and my work focuses on red cell membrane disorders, and I'm very happy to present to use this kind of inherited hemolytic diseases. So we are going to talk about the three main red cell membrane disorders: spherocytosis, elliptocytosis, and hereditary stomatocytosis. So the important thing about red blood cell survival in the bloodstream is their ability to have a high deformability. Deformability is really a cornerstone in the survival of these red blood cells. And each time the deformability will be impaired, there will be a high risk of hemolysis. So deformability is depending on many different factors, and I put some of them here. And you will see that the membrane property of the red cells are important factors that allow this deformability. First, the ratio surface to volume in the red blood cells are very, very important to this to maintain this deformability. The red blood cells have this property to have an important excess of surface in comparison to an isovolumetric sphere, and this excess of surface is a major determinant on the red blood cell deformability. So they have to maintain in permanence this excess of surface, and each time there is an instability of the red cell membrane, you will lose this excess of surface, and that will induce a decreased surface to volume ratio, and this is a hemolytic condition for the red cells. This is what you observe, for example, in spherocytosis, but we are going to talk about that a little bit later. A second important parameter that may also involve the membrane is the internal viscosity, and you can understand that if there is an increased internal viscosity inside the red blood cells, the deformability will decrease. And you can have an increased internal viscosity, for example, in some hemoglobinopathy, but also when the red cell membrane is not able to maintain a constant hydration status inside the red cells. So for example, in hemolytic diseases, where the water is going out the red blood cells, when you have a red cell dehydration, the internal viscosity will increase and the deformability will decrease. This is, for example, what you can see in spherocytosis, yes, but also in dehydrated stomatocytosis, and we are going to talk a little bit later about that. The third very important property is the capacity of the red cell membrane to be elastic, and this viscoelasticity is absolutely essential each time the red blood cell will be exposed to shear stress, and this is particularly true in the spleen red pulp. And this viscoelasticity is directly depending on the structure of the red blood cell membrane, of the protein structure of the red blood cell membrane, which makes these cells so particular. So you have other factors that may also be involved in this deformability, like, for example, energy production, the glycolysis. I mean, the red cell needs ATP to be deformable, but this is less accurate in this presentation, and we're going to focus on the red cell membrane. So this is a very nice representation that I took from the literature, from this article from Bijleveld. And I think it's one of the best representation of the red cell membrane and its particularity. And what you can easily see on this figure is that you have the lipid bilayer, which is a classical lipid membrane, nothing specific about the red blood cells. But the important thing is this protein network that you can see underneath this lipid bilayer. And you can see that it's a network of filamental proteins, which are spectrins alpha and beta that form dimer and then tetramer. And you can see this tetramer, this blue and red little filament. And this quantity of tetramer at the red cell membrane is absolutely essential for the stability and the elasticity of the membrane. So you can see that this tetramer represent a network underneath this red cell membrane and are linked one to each other on a protein complex, which on the right here on the figure. And this protein complex is what we call a junctional complex and is treated by the protein 4.1. So you have the spectrin alpha, the spectrin beta, and the protein 4.1 that are very important in interactions within the red cell membrane that we call horizontal interactions, because they are parallel to the red cell lipid membrane. And each time you're going to have an alteration in these horizontal interactions, you will have an elliptocytosis phenotype. And another point that is very important is that this spectrin tetramer network has be strongly linked to the lipid bilayer. And so you need a protein complex that strongly attach these spectrin tetramers to the lipid bilayer. And this is the complex you can see on the left of this slide. This is what we call the ankyrin complex. It involves the spectrin alpha and beta, of course, ankyrin, the protein 4.2, and the band-3, which is a large transmembrane protein here in a tetrameric form. And this ankyrin complex will really attach this tetramer spectrin to the membranes. This is what we call vertical interactions because it's perpendicular to the surface of the red cells. And these vertical interactions are very, very crucial for the stability of the red blood cell membrane. And each time you will have a defect in these vertical interactions within the red cell membrane, you will have an instability, and this leads to spherocytosis. So you can see that globally, this is what we have here. If you have a weakness in the vertical interactions inside the red cell membrane, you have a hereditary spherocytosis phenotype. Each time you have a weakness in the horizontal interactions, you will have a hereditary elliptocytosis phenotype. And you have a third type of red blood cell membrane disorders that are a little bit different. It is when the red cell membrane is not able to maintain a very finely regulated hydration status inside the red blood cells. And so when you have these red cell hydration disorders, this is what we call a hereditary stomatocytosis. And you have two forms. One is overhydrated, and one, which is way more frequent, is dehydrated. So these are the three membrane disorders that we are going to talk about now. So the first one in terms of frequency is spherocytosis. It's also the best known of this disorder. In a Caucasian population, it involves one birth over 2,500, so it's quite frequent. And it's dominant in 70% of all cases. In 25% of remaining, the 25 remaining cases are de novo or are recessive cases. So as I told a little bit earlier, the phenotype is really directly related to weakness in this vertical interaction. So it's involving the ankyrin complex, and this is another representation for this ankyrin complex. And you can see that it involves protein band 3, ankyrin 1, protein 4.2, and the spectrins. And all of this protein can be responsible for hereditary spherocytosis. So it is not a monogenic disease. It is a disease that can be related to many different mutations in many different genes. All these genes are globally part of this ankyrin complex. In Europe, the most frequent spherocytosis are related to ankyrin 1 mutation for the ankyrin 1 encoding gene. It's most of the time dominant, but sometimes it's de novo. The second in terms of frequency will be band 3 deficiency. It's most of the time dominant. And then we have spectrin beta deficiency, which are globally most of the time dominant or sometimes more rarely de novo. And you have two other forms that are less frequent here. The first one is a deficiency in 4.2 protein. It's really not frequent in Europe. I don't have any patient with this defect, but it's way more frequent in Asia, and it leads to recessive spherocytosis. And finally, you have the spectrin alpha related spherocytosis. In spectrin alpha, it's rare, but it's most of the time severe and it's recessive. And this is something important about spectrin. It's not like the globin chain. So you know that you must have a ratio equal to 1 between alpha globin and non-alpha globin chains, but this is not the same for spectrin. The spectrin alpha is in large excess physiologically inside the red blood cells. So if you have a monoallelic mutation of the spectrin alpha, it won't have that much consequence because there will be still enough spectrin alpha to nicely the tetramer of the red cell membrane. But when you have a biallelic mutation, then you are in trouble. And this is where we can see recessive, severe hereditary spherocytosis. So you can see that all these genes may be involved. The pathophysiology of the spherocytosis, we have a little bit talked about that earlier. So it's a defect in the vertical interaction. So either you will have not enough protein inventory at the red cell membrane, or either you will have not enough ankyrin or not enough or not well maintained tetramer at the red cell membrane. The consequences are the same. It will induce some large part of the red cell membrane that is not connected to the spectrin tetramer and which are unstable. And the consequence of this instability is that there will be vesiculation. And this is what you can see on the right, where you can see little macrovesiculation in electronic microscopy of a red cells. And the spherocytosis is related to this constant vesiculation of the red cell membrane because of its instability. And it occurs very early from the reticulocyte step. So you can see it. This is why often the reticulocyte volume is low in hereditary spherocytosis. And the consequence of that is that you will have a little loss of volume, but mostly a loss of surface. So the consequence is the excess of surface is going to be lost, and the ratio surface to volume of the red blood cells is going to be decreased. So maybe the volume will be a little bit smaller, but most importantly, the surface to ratio volume will be lower, and that will induce spherocyte formation. And what happens to the spherocytes are going to be trapped in the spleen red pulp, because in the spleen red pulp, the local conditions are not favorable for the red cells. The glucose is low, the ATP is low, there is a lot of oxidative stress, the pH is low, and there are a lot of macrophages. So everything that will make a longer passage of the red cells in the spleen cord will be at risk of hemolysis. This is on the left is a very simple representation of what happens in the red pulp, and the particularity of the red pulp is that the red blood cells are circulating in a stroma, not in an endothelial bed, but in a stroma, which is called the red pulp, with a very high hematocrit level within this stroma, and they have to go back to the normal circulation at the spleen sinus. So to leave the cord and to go into the sinus, they need to cross an endothelial barrier, which is represented by this tunnel, and the endothelial barrier is very closed. So the little space between endothelial cells is way smaller than the volume of the red blood cells. And this is what you can see on the right. So the red blood cell have to be highly deformable to be able to pass across this endothelial barrier to reach the sinus of the spleen and then to leave the spleen. So this is probably the most stringent passage of the red blood cells in all their journey in the body. So each time there will be a deformability defect, it's mainly here that the globin, the red blood cells are going to be trapped and are going to be eliminated. And this explains why in this purely loss of deformability phenotype, the spherocytosis, this is why the hemolysis mainly only splenic, and this is why splenectomy is so efficient in correcting the hemoglobin level of this patient. On a clinical point of view, there is no particularity of spherocytosis. It will be the prototype of intratisular chronic splenic hemolysis. And you have many different classifications that have been proposed. This is the Eber classification that have been proposed in children, but you have other classifications. They all say the same thing. So you can classify patients according to their hemoglobin level, to their reticulocyte count, and to the need or not of a splenectomy to treat this patient. Most of these patients have a mild or a moderate spherocytosis with a chronic hemolysis, with some acute liver crisis, when, for example, they experience a viral infection. Often the icterus is more marked and the hemoglobin level decrease. You have also, at the extremity of the spectrum, you have also very, very asymptomatic spherocytosis, what we can call a trait, a spherocytic trait, which may be, for example, a compensated hemolysis. And this is something quite frequent in red cell membrane disorders. You really can have some patients with a normal hemoglobin level, but a very high reticulocyte count. Compensated hemolysis is not exceptional in red cell membrane disorders, including spherocytosis. And at the other extremity of the spectrum, you will have very severe forms that require recurrent transfusion from childhood. And this severe form, for example, can be seen in the allelic mutation of the spectrin alpha, as I told a little bit earlier. So your patients, most of the time, will be in the mild or in the moderate group of patients. But you have some particularity of the phenotype in neonatal expression. And this is true for many red blood cell disorders. The neonatal period is always at risk for a patient with membrane disorders. First, it induces jaundice very frequently, but what is important to know is that when a newborn with spherocytosis, you check his hemoglobin level at birth, and most of the time it is normal. So there is a normal hemoglobin level at birth, but during the first days or the first week of life, you may see the hemoglobin level decrease sometimes drastically, and some of these children will require transient transfusional support. And then after a couple of weeks or a month, you will see an improvement of the hemoglobin level, and they can go back to a very moderate or mild form of spherocytosis. So really, it is important to know that whatever the severity will be later, there is a risk of symptomatic anemia in the first week of life of a newborn with spherocytosis, even if his hemoglobin at birth is normal. And the second thing is that we see more and more patients with spherocytosis and something else, for example, with Gilbert syndrome. And for these patients, there is a 4 to 5-fold increased risk of gallstones, for example, and often very early. And you can also see association, for example, AS trait, sickle cell trait, and spherocytosis. And in this patient, you can have symptoms that you don't get in spherocytosis and you don't get usually in AS, like spleen infarcts has been well described. You can have phenotypic modifiers that may lead to a more severe form of spherocytosis. So how will you diagnose the spherocytosis on a biological point of view? The first thing is to look at the red blood cell morphology using MGG staining. And this is an example on the left of a typical band 3 deficiency. You can see this little spherocyte. What is typical from the band 3 is that some of this spherocyte has a little expansion. This is called mushroom cells. It's not totally specific, but when you have that many mushroom cells, as shown in this picture, you can say that it is very probably a band 3 deficiency. There's not that many publications that evaluate the percentage of spherocytes you can get in spherocytosis. There is one that has been published in 2008 in Hematology from an Italian group, over 300 spherocytosis. And what they observed is that most of patients have spherocytes, sometimes a very low number, but it's rarely absent. The most important thing about this spherocyte is to know that, of course, it's not specific, and you can find spherocyte on the blood smears in many other conditions. And first of all, in immune hemolysis, like alloimmune hemolysis in the newborn or autoimmune hemolytic anemia in adults. And it's very hard to, it's basically impossible to distinguish this spherocyte from a hereditary spherocytosis. So to me, the two main differential diagnoses that you have to have in mind is first, of course, immune hemolysis, but you have the DAT test, of course, and the familial history is lacking in this situation. And also congenital dyserythropoietic anemia type 2, which is rare, which is recessive, but which often is presenting with like a HS-like phenotype with some spherocytes on the blood smear, but this disease is globally less regenerative, and there is a pyropoïkilocytosis on the blood smear that you don't really get in spherocytosis. So sometimes you can have a very deep check on the blood smears, and you can evoke this diagnostic. You have spherocytes in many other conditions. We are going to talk about HPP a little bit later, but in this situation, the spherocytes are associated with the pyropoïkilocytosis that you don't see in spherocytosis. Then after, you can look at the red cell indices, and you have many different blood cell analyzers, and you have algorithms to try to identify HS patients using these different red cell indices. I'm not going to talk about that because it really depends on the system you are using. So what I can, for example, some of these analyzers are able to give you a percentage of hyperdense cells, which are cells containing a concentration of hemoglobin above 41 grams per deciliter. So it has been shown that an excess of these hyperdense cells are basically constant at more than 4% in spherocytosis, but all the blood cell analyzers don't give you this parameter, so you cannot really use it everywhere. So you can look at the MCHC. This is a publication from Thérèse Sinobert that worked with Bicêtre Hospital and taught me everything about red blood cell membrane disorders, and she shows the red cell indices in spherocytosis. And as you can see here, in this series, there were a trend into a high MCHC in this patient. So it would be like hyperchromia. We all know that this is not not a good term. What happens in spherocytosis is that you have a dehydration of the red blood cells. So you have a decreased water content within the red blood cells, and so you will have a higher MCHC. It's not constant in spherocytosis, but a lot of spherocytosis have an MCHC at 36, 36.5, or 37. It belongs to this group of inherited hemolysis that are associated with red blood cell dehydration. And among this group, you find spherocytosis. You also find dehydrated stomatocytosis, and you can also find hemoglobinopathy as well. So once you have evoked spherocytosis, what will be the biological test you are going to use to confirm your diagnosis? So there are a lot of tests that have been described in the literature. There's no way to talk about each of them. It depends on each laboratory expertise. So I'm going to talk about the two tests we are performing now in our lab, but some laboratory still do osmotic resistance test. It's a very efficient test if you do an incubation overnight. Otherwise, you can have false negative. You really need to know the analytic performance of each of your tests to be able to really make an accurate diagnosis. So the two tests we are using now is flow cytometry using EMA staining, and what I consider to be the gold standard in terms of red cell membrane disorder, the osmotic gradient cytometry, which is probably the most sensitive test to recognize this kind of disease. So the first test that is used as a screening test is flow cytometry. It uses a dye, which is the eosine 5 maleimide, that is able to interact with major proteins of the red cell membrane, and mostly the protein bench-free, but not only. Other proteins can also interact with this dye. So you have many publications that show that this EMA test is very efficient in terms of sensibility, in terms of specificity to recognize spherocytosis. And what you are going to measure is the decrease in fluorescence, because you have a loss of surface, a loss of membrane surface in spherocytosis. So you will have a decrease mean fluorescence intensity, and this is what you can see here. It's an easy test to perform. It takes a very few microliters of blood. You can perform it very early in life. We perform it on cord blood cell, cord blood in the neonatal period, for example. It's very efficient, but the problem with this test is where are you going to put the cutoff to say it's positive or it's negative? In France, we use a 21% decrease in the fluorescence intensity to say that it is a spherocytosis. It's not specific. You can have it in other situations like HPP, but the HPP phenotype is totally different, so there is no real overlap in terms of diagnosis. But in spherocytosis, if the decrease of the fluorescence is more than 21%, you can say that your patient in a clinical and biological context of spherocytosis has spherocytosis. The problem is when you have a lower decrease between, we could say, 11 and 21%, the diagnosis of spherocytosis is less accurate, and some very mild cases of spherocytosis can also have a normal EMA staining. So it cannot totally rule out the spherocytosis if you have a little decrease, but not enough in the fluorescence intensity. And it is then in this situation where it's useful to perform more sensitive tests. And the most sensitive test in terms of spherocytosis is osmotic gradient excitometry. It's a very efficient test that has been developed during the 70s years by Marla Mohandas and Marcel Bessis in Bicêtre Hospital. And now it comes back to the front of the line because the system is available commercially. It has been not commercialized for like 20 years, and now it is commercially available. So the principle of this osmotic gradient excitometry is to make the red cell to circulate between the two cylinders, and you will rotate in one cylinder, and so you will expose the red cells to a shear stress, and they are going to modify their shape, and you will measure this modification of the shape, and you will measure the deformability index of the red cells. And this is what you get. This is a normal curve and 3 examples of spherocytosis. So you will measure this deformability index in a medium with an increase of osmolarity, and you will have this curve. And in spherocytosis, I don't really have time to be more precise about this curve, but what we can say is that it's a very sensitive test to recognize spherocytosis in comparison to a control, and it's more sensitive than EMA. It's not totally specific. You can have also this kind of curve in immune spherocytosis, in, for example, hemolytic autoimmune anemia, but this is a different context. But in a context of spherocytosis, it's very sensitive. So what we perform now is EMA test as a screening test, and if it's not totally accurate, if we are not sure of the results of the EMA test, or if the EMA test is negative and we are very sure that there may be a spherocytosis underneath, then we perform excitometry. And as you know, now we have genetic tools that we didn't have like 10 years ago. Now we have NGS, next generation sequencing tools, that are allowing us to sequence all the genes involved in the spherocytosis, but also in other red blood cell membrane disorders. The first thing is that it's not useful for every patient. The clinical decision, are you going to perform splenectomy or not, doesn't depend on, according to me, doesn't depend on the result of the NGS. It's not about what gene is mutated. The only thing is how is the patient, how deep is his anemia, and how is his tolerance to this anemia. But sometimes the phenotypic tests are not relevant, and even osmotic gradient excitometry. And if you need to go to the diagnostic, you may need this NGS, this genetic analysis. First, when you have no possibility of phenotypic analysis, for example, a very severe form of spherocytosis with recurrent transfusion, so you cannot perform analysis on the red blood cells because the circulating red blood cells are also the transfused units. So then you can go to this genetic analysis, and you can also perform this NGS. This is what we do here, and we perform this genetic analysis when there is an atypical spherocytosis. Even if we are sure of the diagnostic, if it looks very atypical, we prefer confirming the data using genetic analysis. So when there is no familial history, when there is a familial history, but when there is a strong discrepancy in terms of severity inside the family. So we think that there may be something that modifies the phenotype. And then also when the screening tests are not conclusive, that we perform NGS. But we have to keep in mind that the NGS is able to give us a lot of different variants in a lot of different genes. And sometimes, and I can say most of the time, the pathogenicity of the variant you identify using NGS is not sure, and the variant has never been described in the literature, so it's very complex if you don't have this phenotypic tool, and if the variant has never been really described before, and it's not clearly pathogenic, to associate this variant with a clinical phenotype. So then how we're going to treat this patient? Splenectomy is, of course, a treatment that can alleviate the hemolysis. Now we are very cautious about splenectomy indication in spherocytosis, way more than it was like 20 years ago. So there are many guidelines. For example, Loïc GARCON was at the head of an international group and published recommendations in terms of splenectomy indications in inherited hemolysis, and this is in Hematological 2017. So what we think, if you have a severe form of spherocytosis with dependency to transfusion, this is an indication of splenectomy, yes, but you will try to perform splenectomy after the age of 5 years, because we consider that before the age of 5 years, the risk of sepsis is higher. So if you can wait after 5 to 6 years and try to perform laparoscopy of robotic surgery more than laparotomy. If you have an asymptomatic or minor form of spherocytosis, there is no need for splenectomy, because splenectomy is associated, of course, with infectious risk, but also with thrombotic risk, and also maybe, even if it's very not sure and discussed, maybe an increased risk of cancer. For these patients, there's no indication for splenectomy. But unfortunately, most of these patients are in between these two situations, and then they can have like a mild anemia, but still decreased quality of life, decreased performance at school for kids. They can have also symptomatic splenalgia, and they can have a very invalidating marked jaundice. And in this situation, you will have to discuss with your patient, keeping in mind that even if it has drawbacks, splenectomy alleviates this hemolysis in this patient and normalizes the hemoglobin level in most of these patients. So one question is, can you just perform a partial splenectomy, not removing the whole spleen, but maintaining a little part of this enlarged spleen? This is what we call subtotal splenectomy or partial splenectomy, and you have recent publications that show that it may be an option, particularly in children. So the interest of subtotal splenectomy is to let around 10% of the volume of the spleen, but you have to keep in mind that it's an enlarged spleen, so even 10% it's enough splenic tissue to probably protect against infectious complications. And I show here the results of a retrospective study we performed and published in 2016 on 79 patients which were partially splenectomized in CHU Bicêtre Hospital, and you can see that there were two main indications of this partial splenectomy. The first one, the group A, was a severe phenotype. These children were young, they have severe anemia, and were most of the time transfusion dependent. So this was the first indication. And the second indication of this partial splenectomy was group B, people which were a little bit older with a moderate phenotype, but were embarrassed by their jaundice or had a kind of chronic fatigue. So this indication was not based on transfusion requirement, but more quality of life and symptomatic fatigue. So when you look at the results, what we can say is yes, partial splenectomy works in terms of anemia, because most of the patients have a very nice hematological response. 90% of these patients had an hematological response, that you can see above, and a decrease in the reticulocyte count. But what is important to keep in mind is that this reticulocyte count remains high. There is some tissue, some spleen tissue. You have spherocytes, so you have a persistent hemolysis. So the reticulocyte count remains high, But whatever, the transfusion requirement for the children that were transfusion dependent was decreased strongly after this partial splenectomy. And there is a very, very important efficiency in terms of transfusion reduction in the children. And in 96% of these cases, the spleen was functional after this partial splenectomy after 1 year. So these are the good point of this technique. The bad point is that you let a little spleen tissue, you have spherocytes, so you have hemolysis, and so you have a progressively growth of the remnant, of the spleen remnants. You can see here with a growth occurring during the 5 years, first years after the partial splenectomy. It doesn't go back to the original large volume, but still it's bigger than a normal spleen. And the consequence also of that is that sometimes this growth of the remnant is associated with relapse for the most severe patient. And in this series, around half of the patient of the severe group needs to go to totalization, I mean, remaining the spleen remnant. But this intervention, this surgical intervention, was performed after the age of 6 years. So when we consider that total splenectomy is safer. So to be brief, I think this can be discussed in very severe patients, very young, which are transfusion dependent, and you don't want them to wait 5 to 6 years to have splenectomy, total splenectomy. So you can propose this partial splenectomy, and most of the time it will alleviate the transfusion need, and then in half of these patients they even won't need totalization later. So this is to me an indication that could be discussed in spherocytosis. So the second red blood cell membrane disorder I'm going to discuss now is hereditary elliptocytosis, which is defined by the presence of elliptocytes on the blood smears, and it depends on the type of elliptocytosis, but it's ranging most of the time from 20 to 100%. It's autosomal dominant, and it's very frequent, but it's not severe at all, and most of the time it's asymptomatic, but it's highly frequent, highly prevalent in some population, like in West Indies or in Sub-Saharan Africa, when you can find elliptocytosis up to 1 to 2% in some population. It's 15-fold less frequent in Europe, but I mean it's a quite frequent situation. So as I told earlier, this elliptocytosis are related to defect in the horizontal interaction within the red blood cell membrane, and the horizontal interaction involve 3 main protein, of course, spectrin alpha and spectrin beta. So spectrin alpha and beta tetramerase at this autoassociation site. And then you have the tetramer of spectrins that are linked one to another at this junctional complex and treated by the protein 4.1. Donc, the same then for spherocytosis. Elliptocytosis may be related to mutation in all the genes encoding these 3 proteins. Most of the time, it's mutation in the SPTA1 gene that encodes the spectrin alpha, and this occurs in 75% of cases. Most of the time, these mutations are located at the N-terminal extremity of the spectrin alpha, which is the extremity close to the autoassociation site, so the tetramerization site. And it's most of the time not symptomatic, just because, as I told earlier, you have a large excess of spectrin alpha in the red blood cell membrane. So if you have a monoallelic mutation, elliptocytosis mutation, you most of the time won't have anything else than elliptocyte on the blood smear, but there will be no hemolysis. The second term in frequency is the gene encoding the 4.1 protein, and this leads to typical elliptocytosis with more than all the red blood cells look like elliptocyte, and it's asymptomatic or very post-symptomatic at heterozygous state. And then after you have fewer, it's more rare elliptocytosis that are related to SPTB mutations, SPTB encoding the spectrin beta. And then, because spectrin beta is a limiting factor at red cell membrane, it can cause more severe form of elliptocytosis. So when you have a weak horizontal interaction, then the red blood cells are going to elongate when they are submitted to shear stress. But when the interactions are even weaker, then the membrane is going to break. There are going to be a fragmentation, and this fragmentation defines the most severe form of elliptocytosis, which is called hereditary pyropoïkilocytosis. I'm going to show you some examples. This is typical from a heterozygous mutation in the 4.1 encoding gene. This is a simple hereditary elliptocytosis. So it represents more than 90% of cases of elliptocytosis. It's asymptomatic, except in the neonatal period. I'm going to go back to that later, but at adult age, it's classically totally asymptomatic. It's most of the time related to monoallelic mutation in 4.1 or spectrum alpha encoding gene, and this is often an incidental diagnosis made after blood smear examination. And to me, I always perform little hemolytic marker and maybe an ultrasonography to check out the presence or not of a splenomegaly, but I don't need a confirmation test. It's enough, and the patient doesn't need, if he doesn't have a hemolytic marker, he doesn't need more specific follow-up. But the thing is, the most expressive elliptocytosis give this kind of blood smears. This is what we call pyropoïkilocytosis, and you can see, you don't really see elliptocyte here. You see a huge poikilocytosis, and you see a lot of little red cell fragments and a lot of spherocytes. This is what we call spherocytes of reformation. It's when the fragments go back to a spherocyte-like shape. And this is typical from a pyropoïkilocytosis. So pyropoïkilocytosis is somehow difficult to recognize on a blood smear because it's very far away from what you can expect from an elliptocytosis. But it's the same category of disease, but it's just more marked, and the red blood cell fragment into the circulation, into the blood flow, because of this stability of the spectrum tetramer. So the octacytometry, the gradient osmotic octacytometry, give you an absolutely specific curve of HPP. This is this trapezoidal curve you can see on the right. So it can be very helpful in pyropoïkilocytosis diagnosis. So when do you see elliptocytosis? When do you see pyropoïkilocytosis? So elliptocytosis, we have seen that earlier. Pyropoïkilocytosis, first, it can be a transient expressive elliptocytosis in the neonatal period. It's exactly the same than in spherocytosis, but the first week of life for a newborn, even if we'll have a asymptomatic elliptocytosis later on, can be very expressive during the neonatal period and can require some transfusion. And then after a couple of weeks or a couple of months, you will be this fragmentation decreased and the hemoglobin level increase and go back to a simple elliptocytosis phenotype. So this is what we call a transient pyropoïkilocytosis, and that improve progressively with months. And sometimes this pyropoïkilocytosis is permanent and leads to a chronic and hemolytic anemia that may be transfusion dependent, and this is what we call HPP for hereditary pyropoïkilocytosis. You see that in some very severe mutation in the SPTB gene. You see that when you have biallelic mutation of the 4.1 encoding gene, and this has been described in some families with consanguinity, and you have that most of the time when you have a composite heterozygosity in the SPT1 encoding gene, meaning that you have one allele received from one of your parents which carry an elliptocytosis mutation, and on the other allele, either you have another elliptocytosis mutation, or either you have a polymorphism of alpha spectrin, which is very frequent because it concerns 20 to 30% of all the population in the world, and which is called polymorphism alpha allele, and this is an allele with a low expression. The protein is half expressed in comparison to a normal allele, and this in association in trans with an allele encoding elliptocytosis mutation can lead to an expressive form of pyropoïkilocytosis, and this is to me an indication of the molecular diagnosis. Why do you have an expressive form of elliptocytosis in the neonatal period? Well, these are all publications, but they're very interesting. They show us that on the left, you have the histogram of volume of red cells. So you have two little peaks. The first peak corresponds to the little microcyte. These microcytes are related to this fragmentation of the red cells, and the second peak corresponds to the normal red cells. And what you can see is from 5 days to adult life, you have progressive disappearance of this microcytic little peak, and this occurs parallelly to the replacement of the fetal hemoglobin by the adult hemoglobin. So it seems that the more fetal hemoglobin you have inside the cells, the more fragmentation you will have, and this is probably related to the fact that the fetal hemoglobin has a very low affinity for 2,3-BPG, and the 2,3-BPG is the molecule that defines the affinity between hemoglobin and oxygen. So in fetal hemoglobin with a very low affinity for 2,3-DPG, the 2,3-DPG is free in excess in the red cells and destabilize a little bit more the red cell membrane and leads to this fragmentation. And when hemoglobin fetal is replaced by adult hemoglobin, the fragmentation will decrease because the 2,3-DPG will then be associated with hemoglobin adult and will not be free in the cytoplasm of the red cells. This is probably why you get this expressive form of elliptocytosis during the neonatal period. This is a typical family we are following here, and you see that the father has a normal hemoglobin level but has elliptocytes on the blood smear, and the mother has a normal hemoglobin level and a normal red cell morphology. And they have two twins, and these two twins have a severe microcytic anemia with a very high MCHC because of this fragmentation. So they have a pyropoïkilocytosis phenotype. It's a persistent pyropoïkilocytosis, so it's HPP. And when we performed the genetic analysis of this family, the father brought elliptocytosis mutation in the SPTA1 gene, and the mother brought this polymorphism alpha-LD, and the association of these two mutations in trans leads to a symptomatic form of elliptocytosis. So how are you going to treat elliptocytosis? It's hemolytic disease, it's multisplenic, so you will perform splenectomy. There's not that many data about splenectomy efficiency in expressive form of elliptocytosis in HPP. We published a couple of years ago a series of 6 patients that underwent partial splenectomy in severe elliptocytosis, and what we saw globally that it was not efficient. I mean, the hematological response were very short and the ruminant growth was very fast. And finally, these 6 patients underwent fastly a totalization of their partial splenectomy. So we consider that subtotal splenectomy is not efficient in HPP. What about total splenectomy? So these 10 patients finally underwent total splenectomy for HPP. And what you can see here is that total splenectomy works because it improves the hemoglobin level, and most of these patients that were transfusion dependent do not require any transfusion after total splenectomy. But in contrast with spherocytosis, the hemolytic marker remains kind of high with a high reticulocyte count, an increased bilirubin, an increased LDH, and a low haptoglobin level. So the splenectomy is efficient in terms of hemoglobin level, in terms of transfusion requirements, but there is still some hemolysis that persists way more frequently than what you observe in spherocytosis, meaning that in HPP, the fragmentation of this red blood cell with very weak horizontal interaction doesn't occur just in the spleen, but also occur in some other places of the circulation. And to finish, I'm going to talk about dysregulation of the red blood cell hydration, stomatocytosis, which are probably the less known of this group of disease. They are very fascinating group of disease. They are most recognized now, and we know that they have some clinical issue and therapeutical issue. We need to recognize them because you cannot treat them like other red cell membrane disorders. So the regulation of the red cell hydration is essential for the red cell survival. It regulates red cell volume, the deformability, the internal viscosity of the red cells. So these are all publications. Globally, what these publications told us is that the regulation of the hydration of the red cell is depending on the sodium and the potassium flow from inside to outside or opposite of the red blood cell membrane. You know that there is an increased concentration of sodium outside the red cell, so the sodium will try to enter. It's a passive leak of sodium that try to enter inside the red cell to equilibrate this concentration. And for the potassium, it's the opposite. You have a higher potassium concentration inside the red cells. So there will be a natural trend for the potassium to be exported to exit the red cells. So in order to maintain this gradient, which is very important for red cell physiology, the red cell needs pump, energy-dependent pump, and this is the role of the Na plus K plus ATP-dependent pump in order to put the sodium outside and to bring the potassium back. So each time you're going to have a mutation in a protein of the red cell membrane that will induce either an increased entry of the sodium or either an increased export of the potassium, the capacity of the pump to counterbalance that, to maybe totally overwhelm, and then you will have a modification of the cationic content inside the red cells. And if you, for example, have a massive entry of sodium inside the red cells, and you cannot have a compensation by the pump, so you will have an increased cationic content inside the red cells, so the water will get in, and you will have a red cell hyperhydration, and this is what you get in stomatocytosis with overhydrated cells. And at the opposite, if you have a mutation in any protein of the red cell membrane that leads to an increased potassium export from the inside to outside, and the pump is overwhelmed and cannot bring back this potassium inside, you will have a decreased cationic content inside the red cells, and so the water will leave the red cells, and you're going to have a red cell dehydration. And this is exactly what you get in stomatocytosis with dehydrated cells, what we call now hereditary xerocytosis. So overhydrated hereditary stomatocytosis, we are not going to talk about that a lot because it's very, very, very infrequent. Only a few families has been described so far. And the pathophysiology of this disease is a massive entry of sodium inside the red blood cells and totally uncompensated by the potassium export, uncompensated by the pump, and the consequence of that is the water will get inside the red blood cells. And this is very important because it gives you this particular aspect of the blood smear with this stomatocyte. You can see many stomatocytes here. And on a clinical and biological point of view, you're going to have a chronic non-ferrocytic hemolysis with a very high reticulocyte count. But what is really remarkable is that the content in water of the red cells is so high that you're going to have a very, very high MCV. So you can see here the macrocytosis, 129 ventilators, and the hemoglobin will be diluted in the huge amount of water. So you have this paradoxical situation with a very high MCV, but a very low MCHC, because the hemoglobin concentration will drop because hemoglobin is totally diluted in this excess of water. So this is very rare. I'm not going to talk a little bit more about that. I prefer focusing on the most frequent form of stomatocytosis, which is the hereditary xerocytosis or dehydrated stomatocytosis. So it's very, very trendy now because most of cases are related to piezo-1 mutation, and I'm going to talk about piezo-1 later, but you know that Arsène Patapoutian received last year the Nobel Prize for his discovery in terms of mechanotransduction, and particularly in terms of piezo-1 and piezo-2 identification. And piezo-1 is a very widely expressed protein. It is also expressed in red blood cells, and gain of function mutation of piezo-1 is associated with hereditary xerocytosis. So this is globally a little shame to resume to evoke the pathophysiology of the dehydration you can see in hereditary xerocytosis. 90% of cases are related to gain of function heterozygous mutation. They are dominant disease of the piezo-1 mechanotransductor. And the mechanotransductor, it is a mutation, it is a protein that is able to transform a mechanical stimulus, a mechanical stress, into a biological response. And the biological response is the entry of calcium. So each time there is a mechanical pressure on the red blood cell membrane, piezo-1 opens up and the calcium enter inside the red blood cells, increasing the intra-erythrocytic calcium concentration. So the gain of function mutation you get in hereditary xerocytosis leads to a higher entry of calcium for lower stimulation. And the calcium inside the red blood cells is able to activate the calcium-dependent potassium exporting channel, which is a Gardot channel. So the Gardot channel open up when the concentration of calcium increase, and then the potassium is exported by this channel. So globally, when you have this increased calcium concentration, the secondary activation of the Gardot channel will lead to potassium export and then red blood cell dehydration. And very interestingly, 10% of hereditary erythrocytosis cases are not related to PIED1 mutation, but are directly related to gain-of-function mutations of the Gardot channel. And in this situation, the Gardot channel opens up too easily for like a normal or supraphysiological concentration of calcium, and there will be a dehydration of the red blood cells. And this is the French team from Catherine Badins in Marseille that described for the first time this Gardot mutation in 2 families. Now there are many different other families that have been published. So if you want to know a little bit more about the clinical and biological feature of this fascinating disease, now you have different publications, and you have the publication for the Italian group. This is our publication we published in Hematology in 2019 about 126 patients carrying PIED1 or Gardot mutation, and all these publications give you a nice view of what you can see in these diseases. And first, what you can see is a basically constant chronic non-spherocytic hemolysis, but it's a mild one, because if you look, this is the result from our publication, you can see that most of patients have an hemoglobin level that is normal. It was 13 grams per deciliter in median, with a high MCV, with a high reticulocyte count, and a trend into a high MCHC reflecting the red blood cell dehydration. So it's really a normal hemoglobin level with hemolysis, reticulocytosis, and a trend into a high MCHC. That is the classical phenotype of the disease. You can see that the hematological, the hemolysis marker are not strongly impacted, and sometimes it's hard to diagnose because the hemoglobin level is normal. It's mostly a compensated hemolysis, and what has been shown last year by our group and also a Filzer group in Blood that published the fact that some patients with hereditary erythrocytosis are not anemic. They even don't have a normal hemoglobin level, but they are polycythemic, and some patients with PIED1 mutation are now known to have a high hemoglobin level, which is totally paradoxal because they have on one side a hemolysis, so a decreased red blood cell survival, but on the other side an increased red blood cell production. So you can see in 5% of the patient, adult patient, polycythemia in this disease. So we explain this polycythemia, and some work that has been done and published last year, by the fact that there is a requirement for a very high ATP production. The ATP is the little gas that allows it feeds the sodium-potassium ATP-dependent pump that is trying to compensate the potassium leak. So you need a lot of ATP in your cells, so you need to have a very high glycolytic rate. And the 2,3-BPG little shunt that is associated, that is a little derivation for this glycolysis, is forgotten because the red cells don't have time to produce 2,3-BPG. They just have time to produce ATP. So the consequence of that is the rate of 2,3-BPG inside the red cells of PIED1 mutated stomatocytosis is clearly decreased in comparison to control. And because 2,3-BPG is defining the affinity of hemoglobin for oxygen, if you have a decreased 2,3-BPG, you will have an increased affinity of hemoglobin for oxygen. And you can check that very easily using either Emox analyzer, but there are not a lot of Emox analyzer available, but you can do just a venous blood gas and try to estimate the P50. The P50 is a reflect of the affinity of hemoglobin for oxygen, and what we show here is that the P50 is decreased in PIED1 mutated spherocytosis in comparison to control or to other red blood cell membrane disorder. So in this complex disease to diagnose, it's true that P50 on venous blood gas help us to recognize patients that can have a stomatocytosis. And this high affinity of hemoglobin for oxygen you can get in this stomatocytosis is probably explaining why some patients are polycythemic, which can seem a little paradoxical at first sight. The second very important thing to know about this disease is hyperferritinemia. this is way more frequent than what you can get in other red cell membrane disorders, and this is the result of the ferritin level in 126 patients. You can see that the ferritin level is increasing with age. These patients are not transfused. The transfusion are very infrequent in this patient, but anyway, they increase their ferritin with time, and they also have iron overload in their tissue. It has been described in the liver. It has also been described in the heart, and there is a very poor correlation between ferritin level and liver intracellular concentration of iron if you measure that using RMN. So what we consider is that if you have more than 500 nanograms per milliliter of ferritin or increased coefficient of saturation of the transferrin, we perform RMI to evaluate the liver iron content and to treat this patient as soon as possible. It's not for all patients. Some patients don't do iron overload. Some other patients do very early. So this is something you really have to figure out. And you can perform phlebotomy in this patient because their hemoglobin level is normal. If they don't tolerate it, some patients are under oral chelation and it works pretty well. But this is one of the most important complications of xerocytosis. Another complication is perinatal edema. This is a retrospective study from University Hospital. And I'm not going to enter in details, but what I can say is that most of the time there is no known familial history of xerocytosis. So perinatal edema can be the entry in the disease. So we have to tell our colleagues that if there is an unexplained perinatal edema, they have to check out the presence of a stomatocytosis in their parents, because this is a dominant disease. It can be severe. Most of the time it's mild, but it can be severe. And we had some deaths in utero and one postnatal death. It can be severe. It's coming usually after the second trimester of pregnancy, and it can sometimes require punction, prenatal or postnatal punction. And sometimes, not frequently, it requires in utero transfusion. Most of the time, it's very mild, so I don't want to be over dramatic here. But anyway, it means that this pregnancy, when one parent, either the mother or the father, is known to have xerocytosis, should be really followed very, very strictly. And most of the time after birth, this perinatal edema disappears after a couple of months, and at the age of 1 or 2 years, they don't appear, they are totally gone, and most of the time there's no relapse. And they are clearly associated with PIEZ1 mutation. We know now why. It has been published in 2015 that PIEZ1 is associated with generalized lymphatic dysplasia. It's more recessive. This is loss of function mutation, but however, it has been shown that PIEZ1 is involved in the development of lymphatic valve, meaning that this is probably why it is associated with this perinatal edema and xerocytosis. And this is finally what you get. You have the hemolysis, you have hyperferritinemia, you have perinatal edema, and what I didn't talk about, you have for some patient a pseudo-hyperkalemia. You can have call from the lab telling you that your patient have 8 or 9 millimole per liter of potassium. It's artifactual. It's really because inside the sample, if you let the sample 2, 3, 4 hours at room temperature, the exit of the potassium from the red cell can really increase this kalemia. And if you control this potassium level just after you do the blood sample, the blood function, it will be normal. So these are artifactual hyperkalemia that should not be of course treated but controlled. And this is how we make the diagnosis. We do osmotic gradient ektacytometry, and the curve is absolutely typical. This is a red curve. You have a left shift curve with a very, very low point or mean point. This means that the osmotic resistance is increased in contrast with spherocytosis. And for people that perform osmotic resistance in xerocytosis or in DHS, which is the same disease, the osmotic resistance is clearly increased in comparison to a normal red blood cell. And then we always confirm now the diagnosis using genetics, and I think that xerocytosis are one of the best indication for genetic analysis in red cell membrane disorders. And finally, this is my last slide. The other thing you need to know about stomatocytosis is that are you going to splenectomize this patient? how are you going to treat them? No, you are not going to splenectomize them because first, most of them have normal hemoglobin level, but the spleen enlargement may sometimes be symptomatic and painful. So you can ask yourself if there is an indication or not for splenectomy of this patient. What you have to know is that there is an increased, a very high rate of thrombosis after splenectomy in this patient. This is the publication we made. I'm going to be fast on that. There are 4 Gardos patients that have been splenectomized, only 1 complicated thrombotic event post-splenectomy, and there were 8 PH1 mutated patients, and 4 patients for whom the mutation was not identified, but they were retrospectively mainly PH1 patients. And on these 12 patients, all of them experienced thrombotic events, 5 portal thrombosis, 5 cerebral strokes, 5 pulmonary embolism. So you can see that there is a very high incidence in thrombosis after splenectomy, at least in these PH1 mutated patients. And so splenectomy is considered globally as a no-go in this patient. First, it's not really efficient. If you have some patient with anemia, it doesn't really improve the anemia. And second, it exposes patient to a very high rate of thrombosis. So you can see that it's a very heterogeneous disease with particular complication, a particular management, clinical management, and sometimes hard to recognize. This was my last slide. I'm very, I will be open to any question if you have some. Thank you very much for your attention.
Thank you very much for this brilliant overview of this specific red blood cells disease. So again, do not hesitate to ask your question. We'll proceed with the Q&A session now. So do not hesitate to shake hands or also ask in live. I can unmute the mic for whom wish to directly ask your question. Yes, or we just received one question. So like you have in the chat box, but I'm reading in live. Does the reduction in red blood cell surface in hereditary spherocytosis have an impact on CO2 and O2 exchange in the lungs or heart that can cause breathing difficulties even if the hemoglobin level in the red blood cells is not affected? So the impact of, in case of spherocytosis, on the ratio and exchange of CO2 and oxygen in the lungs, if it can cause breathing difficulties with a normal hemoglobin, supposed normal hemoglobin. Sorry, yes.
This is a very interesting question. You have ongoing studies that really study that now, particularly from the Lyon team research about that. But on a clinical point of view, this is not what you find. I mean, the people which have a normal hemoglobin level, usually they have a normal tolerance to effort and they don't have particularly range problems. And also, if you take the person which are anemic before splenectomy, it's very depending and there's really no rule. You can have people with 9 grams per deciliter which really do fine and do, for example, marathon and have no problem in terms of sport tolerance and effort. And you have other problems, other people that have 10 to 11 with kind of the same level of spherocytosis and have a huge fatigue and are unable to perform this kind of sport. So there's no really correlation in my experience.
Okay, thank you. Alors, maybe staying on spherocytosis cases, so we saw that splenectomy could be recommended treatment and depending on the age of patient and severity of disease. The question is partial splenectomy in moderate spherocytosis in case of adults.
We have a few patients in the series we have published about that, and what I can say is I will not recommend it because first, partial splenectomy is more complex than total splenectomy, so it's probably more difficult to perform it at adult stage. Now, in children, it's done by laparoscopy, and before it was done by laparotomy. In adults, it's more complex, and in my experience, a lot of people that experience partial splenectomy because they have hemolysis markers, they have fatigue, they have jaundice. After partial splenectomy, you still have hemolysis. So the jaundice will come back. The spleen enlargement will come back. So they may experience the same kind of symptoms they have initially. So if you want to treat a severe anemia and transfusion dependence, it's very efficient because that is proven. It decreases the transfusion rate. But if you want to treat symptoms that are related to hemolysis, you won't really treat them because the hemolysis will be there and will increase in the few years after this partial splenectomy. So this, to me, in my experience, I don't do it in my patients. At adult age, either they have total splenectomy, either they don't, but I don't do partial splenectomy for them.
Okay, thank you for this complementary answers and details about these cases. Alors maybe a last question related to the last disease, the xerocytosis cases. What about more related to biological diagnosis in xerocytosis cases?
Well, first you have a familial history, and you really need to ask very specific question. Is there any pregnancy problems in the family? Is there any like liver cirrhosis because of iron overload in the family? Is there any dominant hemolysis in the family? So these are questions you can ask. Then after you have the phenotypic presentation, it's a compensated hemolysis with the MCV around 100, a very high reticulocyte count. Look at the MCHC, it should be a little bit above the normal, but not always, but if it is there, it helps you. Then look at the blood smear, and it's difficult in xerocytosis because the number of stomatocytes is quite low. It's not obvious like what I show in overhydrate forms. In dehydrate forms, the number of stomatocytes is very low, but it can sometimes it help you. If you practice osmotic resistance, if it's increased, it's definitely in favor of the diagnosis. And after the two main, good ways to do the diagnosis will be osmotic gradient cytometry because the curve is typical, and then confirmation using genetic tool. And
Thank you. Yes, for genetic. Thank you. Thank you very much. Thank you again to Professor Loïc GARCON for this very nice and complete overview of this RBC disease. And only two other extra words. So first, if you like the webinar, I thank you again as usual. So to give us your appreciation in the link below I attach in the chat box, and you just need to click on it. And we will be pleased to be back next month, end of March 29th, for our second scientific webinar with the different lectures from users of hematology LO solutions from different topics and different findings and evaluation on hematology diagnosis. Thank you again. Thank you again, Loïc. Thank you to all, and see you soon.
Goodbye.